everyone. My name is Luc de Catten, and I'm a consultant in fetal medicine at the university hospitals in Leuven, Belgium. And today we're going to talk about the problem of short, long bones. As for the most of us, it remains a diagnostic challenge to distinguish between syndromic and non-syndromic forms, and finally to end up in a diagnosis by new genetic technology. I have no conflict of interest to declare for this presentation. Now, most of us who are in the field for quite a long time do remember the diagnosis of the early ages by ultrasound, on which we relied on fetal skeletal radiology findings to make the diagnosis. And these atlases were made by radiographic examinations of fetuses born with skeletal dysplasias or with stillbirths presenting with skeletal dysplasias. However, when transposing this information to ultrasound images, this was quite difficult, as ultrasound has not the same characteristics as radiography. Therefore, in the early days, when prenatal diagnosis of skeletal dysplasias was made, there was quite a lot of cases in which the diagnosis was not confirmed by the expert in the field. And what we also could see is that although the diagnosis could not be confirmed, quite another type of skeletal dysplasia was presented for which no name existed at that time, or which could not be typed. Over the years, you can see that this did not change very much, as we did rely always on the same criteria, namely these radiographic criteria, and on the run, sonographic characteristics appeared. But due to the lack of evolution in molecular genetics, the diagnosis was in quite a lot of cases not confirmed or incorrect. What we could say is that video radiographs help in reaching, in some of these cases, an accurate diagnosis, and at least it helped in identifying the probability of a lethal disorder. It's not surprising that we made quite a long way to come to the recent classification of genetic diseases, and especially genetic skeletal disorders. And this very recent revision of the nosology of this condition, you can see that today there are over 770 entries and almost more than 550 genes identified that reflect this condition. So therefore, in the old days, when we relied on only a few entries and almost no genetic investigation, the classification of this disease was not very useful, and quite a lot of misclassifications have occurred during this time. Now, in general, bone dysplasias are individually very rare, and overall they account for about 2 per 1,000 births. However, if you look upon lethal bone dysplasias, they account for about 1 in 1,000 to about 1 in 10,000 cases. In clinical practice, most often we are dealing with fetal growth factor receptor 3 related dysplasias, osteogenesis imperfecta type 2, and type 2 cholangiopathies. And this graph illustrates the more frequently encountered dysplasias. You can see the first bar is thanatophoric dysplasia, achondrodysplasia, achondrogenesis, and osteogenesis type 2. These are the most common ones. But there remains quite a lot of cases that are undefined, especially when we're looking at data before the new classification. Key to the diagnosis of fetal skeletal anomalies is the imaging. And of course, this relies on identifying the long bones and measuring the long bones and their shortness, but also looking into other features related to these skeletal disorders. This can be done by, of course, the usual 2D screening ultrasound, which is facing the biometry and assessment of all long bones, in addition to a more extended ultrasound scan by more experienced sonographers looking at the different qualities and features of thorax, mineralization, shoulder and pelvic girdles, and so on. Very recently, over the last 10 to 15 years, MRI examinations became very important in fetal medicine, and this, although in skeletal this morphology is usually not very useful, it can add to the assessment of all other structural defects in these fetuses except for the bones. And finally, on some very rare occasions, we may rely on fetal CT scan, but as in the past, there were some safety concerns related to that, so we'll come to that later on in the talk. The definition of short bones is, of course, related to the biometry of these bones, and you can see that there's quite a lot of discrepancy between what we call short bones. At the top is almost a normal femur length, whereas at the bottom there is a very, very short one related to a severe osteochondral dysplasia. This is only for the femur, but of course we have to look at all the other bones, and if we carefully measure all these bones, we can classify these different bones in terms of their shortness related to each other, differentiating rhizomelic, mesomelic, acromelic, or micromelic dysplasias. In this graph, you can see the different types of classification, radiographic classification of bone dysplasias according to their shortness related to each other. But these are merely examples and are not so important today in looking into skeletal dysplasias. The importance of bone chart has already been mentioned, and this is a paper from Lincitti in 2002, nicely identifying all the different bone elements and representing these in biometric graphs. And this is very important once we come to compare these, the measured bones, the shortness of the femur, for instance, compared to the original biometry or the reference biometry. It becomes very hard when the femur is only slightly shorter, just below 2 standard deviation. At that time, it's very difficult to differentiate this from normal, as we might experience cases with growth restriction, either associated with placental pathology or not, or constitutional growth problems where parents also are constitutionally small, and therefore the diagnosis of short bones is very difficult. In addition, we know that from the past, short femur length and short humerus length have been associated with an increased risk for trisomy 21, as once it was used as a marker, a soft marker for screening for this aneuploidy. And exceptionally, with severe growth restriction and very small abdominal circumferences compared to the head size, we may also think of triploidy. On the other hand, when we go at a very severe shortening, then this diagnosis is often not very difficult, of course, because the huge discrepancies with the normal values of this long bone lengths. But then the distinction between the different entities that are related to these very short bones is very difficult, and therefore we have to look for other clues differentiating these conditions. This, of course, can be done by ultrasound, usually in expert hands, where we look at different skeletal problems. We assess the quality of the bones, look at their shape, look at fractures, for instance, look also at the mineralization of bones in order to distinguish between different skeletal problems. The thorax shapes is very important, and the diameters of the thorax in order to look for lethal conditions. The rib is also very important to assess in order to look for fractures and very short ribness. Hand and feet to have an idea about polydactyly, positioning of the feet, the shape of the skull, and the sutures may play an important role. And in addition to that, facies with maxilla, mandibular, and palate are abnormal in some of these cases. The spine may be abnormally calcified or missing vertebra, and we have to look at the shoulder and pelvic girdles as well, as you can see in some of these sonographic examples. But in addition to that, some of these skeletal dysplasias are also associated with other extraskeletal anomalies, and therefore, like in Holt-Oram syndrome, we have to look for cardiac malformations. There might be renal malformations, as in some type of Jones dystrophia. Fetal movements may be impaired, and maybe ambiguity of the fetal sex, and the amniotic fluid amount might be either increased or decreased. So therefore, a complete overview by ultrasound is needed in order to look at all the different criteria that are related to the shortness of the long bones. And this has nicely been summarized by Pikert and Linschitti in 2019 prenatal diagnosis, when they gave the clues for the sonographic approach to the prenatal diagnosis of skeletal dysplasias. And you see all the different types of anomalies related to the different features are listed. So that means that for all suspicions of skeletal anomalies, all these criteria need to be examined in order to gather the most information possible. And this is needed to classify the bone dysplasias either as dysplasias related to a secondary malformation, like for instance reduction defects or amniotic band syndrome, or relate these bone dysplasias to one bone or a group of bones, as for instance here depicted radial aplasia or polydactyly. And this might be very tricky, because all of these conditions may be related to quite a lot of other features, making the diagnosis of some very severe problems like trisomy 18 or Holt-Oram syndrome, Fanconi syndrome, and so on, in case of radial aplasia, some of which are autosomal recessive or autosomal dominant, and therefore may play an important role for parents in their future offspring. So carefully examination of the fetus upon the diagnosis of one of these features is very important to guide the definite diagnosis and also the future genetic investigation in some of these cases. This slide shows you an Holt-Oram syndrome, a fetus with a radial aplasia and also an abnormal presentation of the hand with absence of the thumb, as you can see, in a twin pregnancy related to a de novo mutation in the TBX5 gene. Finally, all bones may be involved, and in this case, then usually we talk about osteochondral dysplasias, although this might not necessarily be the case all the time. So in such cases, when we have overall short, long bones, we definitely need to differentiate that from the normal or a constitutional problem, which usually ends up by a fetus being normal after birth. Some cases are related to intrauterine growth restriction, either in association with placental insufficiency or in association with other structural defect, and may account for syndromes. Now, the degree of shortening, as mentioned previously, might also account for the different genetic entities which this dysplasia is related with. So shortness between 2 and 4 standard deviations below the mean for gestational age might be more frequently associated with chromosomal abnormality, as this may be a marker for aneuploidy, as previously mentioned, and the shortness of the femur and the humerus length increases the risk for Down syndrome. But in addition to that, there is also an increased risk of pathogenic or likely pathogenic CNVs in about 7 to 8% of the cases. And this is much higher in those cases where the condition of shortness of bones occurs before 24 weeks of gestation. And however, in papers that address this issue is usually not significantly related to the number of associated malformations. In those cases where the femur tends to be below the 4th standard deviation, then more often osteochondral dysplasias are found. And in the paper of Lee, this was related to the conditions of fetal growth receptor factor D in this particular instance. Now, this recent paper in the British Journal of Radiology shows how you can address prenatal diagnosis of severe bone dysplasias in which all members are involved. And as you can see, the features relate to either the cranium, the spine, the long bones, hand and feet, thorax, and also pelvic girdle, but for the sake of simplicity, I left the pelvic and the shoulder girdle out of this diagram. Okay, you can find in this paper a very nice table showing the associations of each of these different abnormalities and the most likely diagnosis related to that. I have tried to illustrate that in this complex graph, showing you that for each of these different types of skeletal malformations, as presented in the yellow bars, different abnormalities can be encountered on each type of these locations in the fetus, as the head, spine, hands, and so on. So this is a very complex graph and is probably not very useful for daily practice, but it shows you that some of these markers are, of course, associated with quite a lot of different dysostoses, and therefore it's needed to look for as many criteria as possible in order to ascertain the diagnosis of one type of skeletal anomaly, which is usually not feasible for quite a lot of bone dysplasias in prenatal life. But for the most common ones, we constructed for our center a table which may guide us through those conditions that we encounter most frequently as osteogenesis imperfecta or achondrogenesis, hypophosphasia, thanatophoric dysplasia, and so on. And this may be very useful because it's rather simplistic and relates on very limited criteria of abnormalities in the skeleton. For instance, the hypermineralization, bowing, fractures, and so on. So this might be very useful as a daily tool to use in the clinic. This example, however, shows you that the simplicity might not always lead to the correct diagnosis, as these two cases resemble each other very well. On the left side, you can see that this is a fetus with a severe micromelia. Both hand and feet are abnormal. There is also the impression of a skeletal anomaly at the level of the ribs, and you can see the mineralization of the spine is rather bad. In addition to that, in the clip, you may experience that at the top level, at the cervical region, vertebrae are not really calcified. And the second image, case 2, actually looks very similar, also has a micromelia present, also abnormal calcification of the vertebrae are present. And actually, this case may look very, very similar, although these represent by, although these cases by ultrasound do not differ very much, the diagnosis afterwards were completely different, as case 1 was a case of hypophosphatasia and case 2 is a case of achondrogenesis. So you might be misled by only ultrasound markers. And this may happen quite often in the literature, as you can see that a complete characterization by ultrasound alone is feasible only in 1 out of 5 cases. If you do add a pathological examination, you increase the characterization to nearly 50%, and additional genetic testings adds about 10 to 15% to that, so that in the end, if you do add genetics and pathology together to the ultrasound science, you may end up by about 80% of correct characterization in skeletal anomalies. In another paper by Ye et al. Shows that the final diagnosis in association with pathological examination, radiographics, and molecular diagnosis is about 70%. But there's still some misdiagnosis possible. However, if you look into the prediction of lethality of the condition, this was always 100% correct, which is also very important in order to counsel correctly the patients. How do we predict the lethality of skeletal dysplasias? Well, there are several parameters we can use for that. But some of them are very obvious, of course. If the micromelia is very severe and finger length is below 4 standard deviations of the mean, this signifies that there's a very important skeletal anomaly. Skeletal narrowing of the thorax, of course, is also very important. And this can be either seen by measuring the cardiothoracic index, showing that this, of course, the heart is way too big for the thorax at that time. The fetal lung volume are very small and it can be estimated either by 3D ultrasound, which is rather time consuming and not very correct, but MRI is a more friendly tool to estimate fetal lung volumes. The thorax to abdomen ratio is less than 60% by ultrasound, and the ribs do not encircle more than 50% of the thoracic circumference. Is also a very good sign. As you can see in the video clip, this is what we call the champagne cork appearance, where the thorax is very small and the liver bulges below the thorax, giving you the appearance of a champagne cork. Presence of multiple fractures also indicates a very severe skeletal dysplasia, and also, as in other instances when hair drops is present, this has a bad neonatal outcome. Is there an additional role for other imaging tools? Yes, of course there is, although that fetal MRI usually is not the best tool to evaluate long bones in se. It may add to the determination of fetal lung volumes and to discriminate additional malformations. And these might be very important to finally come to the final diagnosis of the dysostosis or the skeletal malformation, and also determine the prognosis. You can see that the accuracy of fetal MRI related to ultrasound, even in experienced hands, that the accuracy of fetal MRI might be just a little bit higher, the sensitivity might be just a little bit higher, although the specificity for these two examinations is almost the same. So MRI might add, especially to the extraskeletal anomalies present, to differentiate between severe conditions. As previously mentioned, there is perhaps a small role for low-dose fetal CT scan. This has been addressed recently by Snyder and colleagues, as they showed that the low-dose fetal CT may provide value information, especially in those cases when the specific diagnosis remains uncertain, or when molecular genetic testing is unavailable or not warranted by the patients. Okay, So this additional information gained by CT may also be able to gain potential genetic testing and assist in counseling the patients and plan the delivery more carefully. However, the use of fetal CT should be carefully considered based upon specific clinical case and is best done in the setting of a multidisciplinary team, because of course the input of the geneticist and the neonatologist might be very important to guide not only the indication for the CT scan, but also to interpret the results and to counsel the patients properly. So we in our center only perform in very occasionally low dose CT scans in those cases with severe skeletal dysplasias where prognosis might be not very clear or where parents are very reluctant to accept the conclusions of our counseling. It should only be done after completion of organogenesis, of course, and in the table you can see those skeletal dysplasias that were mentioned by Snyder et al. That might gain from CT scan to have a more proper assessment. There's still remains the point of safety of prenatal low-dose CT scans, and in the table you can see the doses of radiation by the most recent scans addressing this issue, where you can see that for most cases compared to the literature in our center at least, we stay below, far below 10 millisievert, and this is I think very important, as we know that the radiation's effect of radiation below those of 50 millisievert is the impact is very mild to none in case of the performance of these CT scans prenatally. So the absolute risk of fetal affection related to this examination is very small and definitely neglectable at a dose below this 50 millisievert. Nevertheless, also this paper addresses the issue that the examination should not be performed in the absence of a radiologist and an X-ray physician at the time of the scanning, and retrospective analysis between radiologist and medical physicist should evaluate maternal and fetal data to compare radiation doses and image quality for accurate dose protection. So it's very important to work as a team together if you perform this to optimize the efforts you put in the CT scan and to optimize also the final results. So this shows you some examples of prenatal CT scans in cases where we thought it might be again in the determination of the prognosis. These two cases are cases in which there are, besides severe vertebral anomalies, also rib fusion anomalies, and it was very hard to predict the final outcome without these issues, because the problem of thoracic mobility and excursion of the ribs could not be assessed properly by ultrasound, because we were not able to see correctly all the fusions and abnormalities of the ribs. So here it was very helpful in determining the prognosis together with the thoracic surgeon and the neonatologist to counsel patients rather about the severe and bad prognosis and to decide to come to a termination of pregnancy. Now, as mentioned previously, the differentiation between several skeletal disorders remains very difficult, because they have characteristics that are present in quite a lot of these dysostoses, and therefore we cannot always rely just on our ultrasound, even MRI and CT observations to determine the exact nature of this osteochondral dysplasias. Therefore, we need additional tools as there are genetic testings in order to ascertain the final diagnosis. And as we look into genetic testing, we know, of course, that we had the classical karyotype, which now has been abandoned, and also the molecular karyotype, which has become the standard of care over the last years. If you look into the results related to, or the sensitivity related to genetic testing, then you can see that for karyotyping and array comparative genomic hybridization, the yield is about 30 to 40% of conditions that can be correctly analyzed and give a final result or an abnormality, leaving us with about 60% to 70% of undiagnosed cases. Now, the point is that in those cases that are undiagnosed, there are quite a lot of single gene disorders. We know also that the fraction of gene disorders, single gene disorder, is higher in some categories of defects than in other ones. Now, skeletal anomalies is one of the major groups in which this may be true. Now, when we look at genetic investigation for one of anomalies with one or few genes involved, then of course we can rely on traditional PCR examinations or Sanger sequencing, as the number of genes to be looked upon is rather small. However, if hundreds or thousands of genes are involved in, for instance, multiple anomalies or skeletal dysplasias, then of course this technique is not very useful anymore, very time consuming, and would not end up by giving us a correct diagnosis. Therefore, new techniques as next generation sequencing, massive and parallel sequencing are necessary in order to quickly assess the genome. And this can be done with exome sequencing, as shown summarized in this slide, going by the fragmentation of the genome and DNA extraction, then apply a ligation to these different fragments, and finally try to capture the exomes and then sequence these exomes because they do represent, of course, the most important part of genome as far as we know today. This can be done either by analyzing completely the exome, and this accounts for about 90% of all coding sequences, or by using gene panels, and these gene panels may be related to multiple genes that are selected and relevant to a specific disease disorder like skeletal dysplasias, for instance, or for central nervous system anomalies or developmental disorders, and so on. In the end, all these different reads of the patient are referred or at least compared to a reference DNA, and several variants are of course detected, and these variants may or may not lead to the final diagnosis. Now, as you can see on the right hand side, any individual carries about 3 million variants in his DNA compared to a reference DNA, and of course not all of these variants are pathogenic. And finally, only a handful, let's say about 20, are predicted to be pathogenic, and therefore it's very important that at that time to match completely with the variant that is pathogenic, we need to have reliable phenotypic data to match these variants with the clinical problem in order to exclude those that are not relevant. So that is very important. And now again, all these efforts that we do by ultrasound scanning and adding all these markers become important to the geneticist, because they can now exclude variants that are probably not related to the condition and identify the one that is that matches the phenotype. Now, what do we expect from this exome sequencing in those cases where the karyotype an array comparative genomic hybridization are non-diagnostic or have been normal, well, you can see that overall in about 30% of cases there is additional information by the exome sequencing. And this may differ significantly from cases where if you consider all structural anomalies together, where the additional effect is about 15%, to those cases that are very selected and where you have a high risk for single gene disorder, and then the information might increase up to 42% of the cases. So what are groups that might count for a higher sensitivity when we apply WES? So here in this slide, derived from the paper from Mellis et al. In 2022, you can see the diagnostic yield related to the type of anomaly. This was a meta-analysis done on 4,350 fetuses, and the authors classified these fetuses according to the type of malformation. And you can see there are groups that score very highly in the additional diagnostic information related to exome sequencing, and groups that score very low. The groups that score very high are skeletal malformations, where up to 50% of the cases information was found on exome sequencing. The group that scored very low and is unlikely to have gained additional information from the exome sequencing is isolated nuclear thickness and renal malformation. Does it matter if in this group of skeletal anomalies the skeletal anomaly is isolated or non-isolated? We can see also another systematic review, a meta-analysis of 19 studies having information on just over 450 fetuses by the group of Mohn in 2022, and this group was composed of 160 fetuses with uterine growth retardation and short long bones, or short long bones either isolated or with other skeletal findings. And you can see that in those cases where the short bones are isolated or in addition with skeletal malformations, in both cases exome sequencing had a high yield of high diagnostic yield in those both instances. When it was only related to isolated growth restriction or even growth restriction with associated malformations, the yield was much lower. But the lowest was for isolated growth restriction, especially in those cases where placental pathology was involved. The incremental yield was only 4%. All the other cases, the incremental rate yield was more than 30%, and short bones with other skeletal malformation nearly 70% of the cases. So therefore, upon the diagnosis of short bones related to growth restriction and without other associated anomalies, and where placental insufficiency might be the most common determinator, exome sequencing might not be indicated as the yield is too low to perform this type of investigation. Finally, this is another paper by the group of Che, very recently published, showing you that in their systematic review of 10 studies, counting 226 fetuses with normal array and normal karyotyping, performing exome sequences in those skeletal anomalies resulted in a diagnostic yield of 69% of the cases, and 10% more in those cases which were not isolated compared to the isolated short bones. But also remarkably in their paper was that they addressed the diagnostic yield in specific features of the skeletal anomaly, and you can see there are at least two skeletal anomalies that have a higher yield, and that is a small chest and abnormal skull and macrocephaly, compared to, for instance, absence of limbs or abnormalities of the phalanges, which scored much lower. So it's very important, therefore, to address in our prenatal examination all the features related to skeletal dysplasias in order to have the most important information and yield of the additional examinations as exome sequences when we perform it. Finally, when we look upon new possibilities in diagnosis of skeletal disorders, we of course now do genetic screenings testing on all pregnancies, in Belgium at least, for aneuploidy by NIPT, by non-invasive prenatal screening or testing. But it has also been addressed for skeletal dysplasias, and in this paper by Moon, they looked into several thousands of patients and fetuses with abnormalities, normal and abnormalities, and they looked for the possibility to detect pathogenic or likely pathogenic variants in cell-free DNA from the mother for about 25 conditions in 30 different genes after 9 weeks of gestation. And they also did maternal and paternal testing on the side. As you can see in both figures, you can see that for skeletal anomalies, there are quite a lot of positive cases identified by this non-invasive screening in the maternal blood, and the most important one is the abnormal ultrasound finding as long bones, in which about 30% positive results were encountered on a non-invasive prenatal screening. So this may be important for future development in screening for skeletal anomalies, but probably is not screening for patients not at risk, because the chances of having a false positive result remains very, very high because the low incidence of the condition. So to conclude, fetal short, long bones remain a very important diagnostic challenge for most of us, especially those cases where the mild discrepancy between the normal ranges and in terms of differentiation between normal and growth restriction, and on the other side